Welcome everyone to the highlights of the first World Stroke Organisation webinar to be hosted by Stroke Connector. Stroke Connector is the new online hub for WSO members, and it will focus on user-driven content. It is a place where you can access and share advocacy and stroke support case studies, resources and reports, view profiles of other users, and join in or start discussions. There will also be a webinar programme hosted by Stroke Connector and a calendar of users' events. You can register for Stroke Connector if you're a WSO member at strokeconnector.worldstroke.org, or if you're not already a WSO member, you can find details on the WSO website under Membership and Join WSO. So now more than ever, we know how important it is to be connected as a global stroke community. And we want this hub to be a place where you can access and share resources that can help us to drive better outcomes in stroke globally. So we were really pleased to have Dr Harry McNaughton present at this first webinar for Stroke Connector. Harry trained as a doctor in New Zealand and the UK, and has worked in stroke rehabilitation for over 20 years. Harry worked for 3 years as a volunteer physician in rural northeast India. He was principal investigator for the Taking Charge After Stroke trial, which was published in April in the International Journal of Stroke. Harry's life passions are addressing social injustice and ensuring there is a healthy planet for his children's generation and those that follow. So we're very pleased to share with you Harry's presentation and the question and answer session.
Okay, good morning, good afternoon, good evening, everybody, wherever you are in the world. Kia ora koutou katoa. Greetings to all the people in Aotearoa, New Zealand. It's lovely to be here. Today, I feel really privileged to be part of the WSO launch of the Stroke Connectors online hub. I think this is going to be an amazing resource. I'm also very excited about the fact that this is a stroke rehabilitation webinar. Stroke rehabilitation has often been the poor cousin of acute stroke and hyperacute stroke care, and it's good to have this voice today. I'm very happy to welcome Mark Vivian, who's CEO of the Stroke Foundation of New Zealand, the major stroke support organisation in New Zealand, and he's kindly agreed to say a few words at the end. So today I want to engage your imaginations. Take Charge is a different sort of intervention that has great potential for people with stroke, and I'd like you to think about it in a different sort of way. For those people who are watching the recorded version of this webinar, I'm putting the main messages up now just to encourage you to carry on watching. So there's now level 1A evidence of effectiveness for Take Charge in the community phase of stroke rehabilitation, improving outcomes at the level of independence and quality of life. And the main results have been published this month in the International Journal of Stroke. The link to that paper is on my last slide. And so today I'm not going to go over the results in any detail, and I'll leave you to read the paper. But one of the responses that we get a lot from these results is, how can this possibly be true? This sort of disbelief in the results, that here's an intervention that's not started until 6 weeks after the stroke on average. It only involves 1 or 2 up to 60-minute sessions of talking with no therapy, but still achieves remarkable results at 12 months after the stroke. And so today I think my job is to try and address some of this disbelief and show you that it is really possible for Take Charge to be effective in this way. I want to get you excited about using Take Charge. I think this is self-explanatory. And I want to go over a few of the practical issues with using Take Charge and answer any of the questions you might have as we go along. Feel free to email me or get in touch with me on Twitter if you've got questions after the presentation. So this has been a team effort over a long number of years. I want to thank everybody at the Medical Research Institute of New Zealand, and in particular a fantastic backroom team. So I want to start with the International Classification of Functioning. This is the cornerstone of rehabilitation theory and practice. And it's easiest to think of this in a rather linear way, so that the stroke causes a problem with body structure and function, like weakness of one arm. That in turn leads to problems doing things like washing, dressing, walking. That in turn leads to problems of participation and life interactions like work, study, being involved in the community, and in turn has an effect on quality of life and independence. The impact of the stroke is modified by environmental factors and personal factors. Lots of surveys of adults living in the community agree that people value outcomes at the level of life interactions, quality of life, and independence. So the focus of hyperacute treatment is to try and reduce the damage in the first place. The focus of orthodox therapy-led rehabilitation is on activities of daily living and removing environmental barriers. And there's good evidence that therapy-led rehabilitation improves activities of daily living. Unfortunately, there's been several large randomized controlled trials of optimizing therapy-led rehabilitation, more therapy, earlier therapy, different types of therapy, robot-assisted therapy, which haven't shown an impact on quality of life and independence. The focus of Take Charge is on the personal factors box, which we think needs to be larger. And now there's 2 randomized controlled trials of moderate size showing that Take Charge, in addition to best hyperacute treatment and in addition to best therapy-led rehabilitation in hospital and the community, improves outcomes at the level of participation restriction, quality of life, and independence. So I just want to unpack the box of personal factors a little. The WHO lists these parts of the personal factors box, and the ones that I've highlighted in bold relate to motivation. And motivation is a difficult concept, difficult to fully understand, difficult to measure, and up till now, we've felt as rehabilitation clinicians that it's difficult to manipulate people's motivation. So I just want to make it clear what our view is, and that's without a motivated patient, successful outcomes from rehabilitation are very difficult. And now we've shown that Take Charge targets motivation and improves outcome. And if we're right, that will change everything. So now I've got 3 ways of looking at Take Charge, which I hope will help you understand how it might work and also help you explain it to other people. And in the first of these, I want you to imagine the person as a car. Now the car is the engine is the thing that defines the car, and the person equivalent of that is the sense of self, who I really am as a person. What makes the engine run is the fuel. And for the person, that's their intrinsic motivation. The ingredients of the fuel are really important, and we call them by this acronym AMP-C. The most important of these is purpose, but also autonomy, mastery, and connectedness. Everything else about the car is useful, but not essential. It's the other bits. So now I want you to imagine two people and their life journey, which is going to end up with a stroke. So at the start of the life journey, both the vehicles start with the same amount of fuel. On the upper journey, this person has had quite a few ups and downs in their life. They've had to overcome adversity. They've had to develop resilience. And by the time they get to their stroke, they've got a tank full of intrinsic motivation, rich with purpose, autonomy, and mastery. On the other hand, the person in the lower journey has a rather easy way through life. It's never really been tested very much and is now in middle life, is a bit unsure of where he or she is going in life, and arrives at the time of the stroke with a fuel tank rather empty. Now, the stroke itself is going to have an impact on the person's fuel tank, but the person on the top line who had a full fuel tank to start with is likely to make the most of their rehabilitation and do well. On the other hand, the person on the lower journey, by the time they've got through the immediate stroke period, their fuel tank's empty, they're going nowhere. In that sort of situation, it's difficult to imagine that any amount of therapy is going to make a lot of difference to somebody with no intrinsic motivation. The Take Charge intervention aims to help people top up their own fuel tank and improve the trajectory of their outcome after stroke. Intrinsic motivation is from within. It's what you do for yourself. Whereas extrinsic motivations are like bribes. You're doing this in return for something, whether it's a cash reward or praise, just pleasing other people. So what we're trying to do is for people to increase their own fuel, not for us to be pushing their car. There's lots of evidence from the education and the psychological literature that people who are intrinsically motivated do better than people who are extrinsically motivated. Those of you who have had teenagers know this already. External motivators tend to be short-term. The results, the benefits tend to be short-term, whereas intrinsically motivated people keep going. So enough theory. I want to talk now about a real person. This is my second illustration of Take Charge. So Julia had a big stroke. This is what the rehab team said about her in the multidisciplinary team meetings and in the clinical notes. Julia was adamant that she was going to get better and she wanted to mobilize as much as possible. But she was told that she was only allowed to mobilize with trained staff. And so she tended to wait until the physios had gone home and the nurses had retired to their workstations at 5 o'clock, and then she'd get herself up either on her own or with her husband and try and walk. And she fell many times. She and her husband were in a constant battle to get more therapy, more time at home, more car transfers. She was determined to improve because she wanted to get back to work and she wanted to be with her family. She was told many, many times, Julia, you can't run until you've learnt how to walk. Now, we've all seen patients like Julia, and I just want to ask you to reflect for a minute whether you think that patients like Julia tend to have better than average outcomes, middling average outcomes, or worse than average outcomes. Most people agree that Julia is going to have a better than average outcome, which she did. Julia was taking charge. She had plenty of fuel in her tank. The Take Charge intervention tries to operationalize Julia. for people who don't have as much intrinsic motivation as she does. We know from qualitative work that there's a continuum of the ability to take charge, and Julia is clearly at an extreme end of that continuum. And people further down that line have less ability to take charge. What we're trying to do with the take charge intervention is shift the whole distribution to the right, so that on average outcomes are better. So how did we help people top up their fuel tank? So in a single sentence, we got them to look beyond their stroke. What we did was very simple. There was just 1 or 2 sessions, 6 weeks apart, up to around 60 minutes or so in the community. And we trained our facilitators with about half a day of training only. And the main part of the training was to get them to listen and shut up themselves, so that all the ideas came from the person with stroke and their family. A lot more detail is in the training manual, which you can download from the MRINZ website, and the address for that is on my last slide. Take charge is aimed at the roughly 50 or 60% of people who were discharged home to community living, not fully recovered from their stroke. So this is the third way of looking at take charge. In a single graphic, what we're aiming for is a transformation from the person on the left, who's a stroke person, overwhelmed by the stroke and the baggage associated with it, and transform them back into the person who they really are, a person who happens to have had a stroke. The next 3 slides show the first 3 pages of the Take Charge booklet. It's available for download from our website along with all the other materials. So this first page develops the idea of the 2 circles graphic that I showed you on the last slide. The person with stroke and their family can fill in the gaps. The second page develops this idea further. Sometimes it's easier for people to talk about their fears rather than their hopes. But this is the idea of looking beyond their stroke, at what they're looking forward to. Sometimes visualizing and drawing is easier and more powerful than writing. And so this is a chance for people to draw what their best day would look like. This is an idea borrowed from palliative care, can be very powerful. People are asked to imagine a place, people, and action to fill in this page. There's also an extra pages at the end of the booklet if people want to have another go at it. There's further pages which deal with common issues after stroke with a structure to help people plan for the future. The booklet stays with the person with stroke, and so they can add to it at any time. So it's not necessary for this all to be filled in at the time of the Take Charge session. So briefly to a few numbers about effectiveness. So the first measure of effectiveness, our primary outcome measure, was the physical component summary score of the short form 36. This is a measure of health-related quality of life. And we know that the minimal clinically important difference of this scale is about 2 to 3 points. So in this graphic, the difference between take charge and control is along the x-axis here, and any results to the right of this vertical line indicate that take charge is better. And so in the first study, 172 Maori and Pacific people in New Zealand, the difference between take charge and control was about 6 points on the short form 36 PCS. That was published in 2011, and the most recent study of 400 mainly white New Zealanders, was published this month. And that showed a difference of about 3 points on the PCS of the short form 36. Overall, the difference is about 4, statistically significant with relatively small confidence intervals. You may be more familiar with the modified Rankin score, which is a measure of functional outcome after stroke. Scores less than 3 indicate independence, scores of 3 or more increasing levels of dependence. So again, clinically and statistically significant difference in both the Maori and Pacific stroke study and the TACAS study, and overall the results show that you need to treat, the number needed to treat for 1 more person to be independent at 12 months is about 8. What we were also able to show that there was a statistically significant difference in the dose of take charge, so that there was an increase in the PCS with 1 session, about the same extra increase in 2 sessions. And as yet, we haven't tested further sessions. We don't know whether that would increase outcomes further. I'm often told that by people working in therapy teams, oh, we're already doing this. We already do person-centered goal setting. Well, actually, there's pretty good evidence that that's probably not the case. I have 2 simple tests to determine, in my mind, whether what people are describing as person-centered goal setting or not. The first is whether they use the term patient-centered goal setting, which sounds to me very stroke-centric rather than whole person-centric. And the second is I ask them, during the goal-setting process, who's holding the clipboard and the pen? If it's not the person with stroke, usually makes me feel that this is probably not person-centered goal setting. This is a simple illustration of what we think the differences are between traditional goal setting and take charge. This is not intended as criticism, just reflection on the differences. I just want to highlight 2. So in traditional goal setting, the therapist tends to have a role as teacher or coach and tends to be doing most of the talking. Whereas in take charge, the facilitator is trained to listen and not talk and only reflect the person's own thoughts. And the second is that take charge is anti-SMART. So SMART goal setting may be good in factories and places where efficiency targets need to be met. But our concern is that it tends to lower horizons for people. We want people to dream big, think about work and study and new things, travel, going to be able to go and see their granddaughter play football on a Saturday morning. We don't want them to have to lower their horizons just to make the goals in some way realistic and measurable. So to summarize, here's the ICF again. And this is where we think take charge is having an impact. So the summary of the measured impacts from the take charge studies show that there's a relatively small impact on activity limitation, but larger impacts on participation, quality of life, and independence. And it's cheap. This is for 2 take charge sessions. Another way of looking at the impact of take charge is comparing it to other stroke treatments in terms of number needed to treat. And take charge clearly measures up in that way. But perhaps more important is when you think about how many people you can help with an intervention. And what this slide shows is that the stroke rehabilitation interventions like stroke unit care and take charge, because they can be applied to a large proportion of the stroke population, they can have a big impact on the number of people with stroke that are helped. in comparison to interventions which can only be applied to a limited amount of the stroke population. And for me, this is what encourages me to that stroke rehabilitation needs to be developed, and we need to be looking at more stroke rehabilitation interventions because of the overall impact they can have on the life of people with stroke. I want to emphasize again that Take Charge is an addition to best stroke rehabilitation. So, is this sufficient for us to change clinical practice? You know, the level of evidence for Take Charge we think is compelling, and certainly there's things we do in stroke now where the level of evidence isn't as great as this. But if you're going to use Take Charge, you've got 4 decisions to make. You've got to decide which patients, whether you're going to build this onto existing current rehabilitation services or integrate it into current rehabilitation services. You need to identify a facilitator and think about how they're going to train them. I've got some suggestions there about that. And you may need to make some alterations to the Take Charge booklet, especially if you're going to use a language other than English. We're very happy for you to do that and to send any translations back, which we will post on our website for others to use. So to come back to Runa, who is from Assam and northeastern India, she had a severe stroke and she rehabilitated herself. She only spent a few days in hospital. She never saw a physiotherapist or occupational therapist, but she was driven by the need to get back to her farming so that she could send her child through school. Just to summarize the main messages again. So what I'd like you to do is try Take Charge for yourself. All the materials are there to download and use. Contact details are on the last slide with any questions you have. I've shown you 3 different ways of thinking about Take Charge, and I hope that that helps you both understand the intervention, but also allows you to explain it to other people. You know, I think there's enormous research potential opened up by these results from Take Charge, not just research about the Take Charge intervention, but other interventions either improving it or going side by side with Take Charge. I also think that there's a lot of room for integrating Take Charge with new therapy interventions to see if we can improve outcomes for people with stroke. So please get in touch. Thank you very much for listening, and I hope you enjoy using Take Charge. The link to the International Journal of Stroke paper is at the bottom of this particular slide.